Next is about the imbalances of electrolytes. Among them, the first is the hypernatremia. If the sodium level is raised, the sodium level raised conditions can occur either as a result of hypovolemia. If the total volume of water content is reduced, then the sodium level will be raised, or euvolemic, where the volume would be the same as at normal, or hypervolemic, where the volume of the circulation also is increased along with the sodium. And the important is patients who have renal pathologies, patients who are on administration of drugs like diuretics, or patients with renal diseases, they may have a hypovolemic hypernatremia. Or there could be conditions like vomiting, diarrhea, burns, where there is water loss, like dehydration. Majority of the dehydration conditions where the water is lost, patients may have hypernatremia. Euvolemic hypernatremia can occur as a result of diabetes insipidus, where there would be more loss of potassium and the retention of water also. Then hypervolemic conditions, like when the patient is administered a high amount of hypertonic saline sodium, or the bicarbonates, sodium bicarbonates is administered, then there could be hypervolemia, or even diseases like Cushing syndrome, it can occur. The symptoms of hypernatremia can occur when the sodium level is more than 160 millimole. In the early stages, initial stages, the symptoms may not be very significant. And if the hypernatremia occurs rapidly, as in case of IV infusion, the symptoms will be more prominent. Whereas chronic hypernatremia is well tolerated because there will be a compensation, and hence the symptoms will be much less prominent, or many times the patient may not have any clinical symptoms. And hence the clinical symptom assessment often can result in a wrong assessment of dehydration, and weight loss is more reliable. The child, particularly in children, the child may appear much more sicker than the other conditions of dehydration if there is a hypernatremia. And the shock occurs late because of intravascular volume is relatively preserved. Though the child is dehydrated, if the sodium level is more, the signs of shock may not occur till very late, and hence again there is a chance of missing the evidences or missing the diagnosis. The common clinical symptoms are lethargy, irritability, the skin is felt duffy as in any case of dehydration, or there could be even cerebral symptoms like ataxia, tremors, or increased reflexes, even seizures, or Glasgow Coma score may get altered, reduced, resulting in impaired consciousness. Correction of the hypernatremia is mainly done by giving water, plain water, or 5% dextrose in water is given. So adding water is the main treatment of hypernatremia, particularly in hypovolemic or euvolemic conditions. In hypervolemic conditions, usually a diuretic is enough. The correction has to be, particularly in children, it has to be a slow process, and the correction factor should be, that's the total amount of the fluid which has to be given would be 0.6% of the total body weight into the sodium level, the altered sodium level. It's how it has to be calculated. In elderly persons, it can be 0.5. In children, it could be 0.6, the multiple factors. So that's about the hypernatremia. Clinically, the incidence of hypernatremia are less common and comparatively less important. Whereas hyponatremia, reduced sodium level, is more common from the clinical point of view and also more important. Most of the patients whom we see in the clinic, they are of hyponatremia complications than the hypernatremia complications. And the hyponatremia can occur due to deficit of sodium as well as water, or it could be due to excess of water, or there could be the water in excess of water in the body, and hence it may present again in the same fashion as the hypernatremia, as a hypovolemic, euvolemic, or the hypervolemic conditions. Hyponatremia can occur due to the pathologies related to the kidneys, where there could be excess of diuretic being given, or if the patient has a steroid deficiency, a huge number of patients whom we see of cerebrovascular accidents or poor general conditions, old age patients with the hyponatremia, they have the mineralocorticoid deficiency. There would be abnormality of the steroid secretions in the body, and that results in hyponatremia. Our patients may have, so we often see in our ward the patients of old age, or maybe these particularly stroke patients. They are mainly, they have a corticoid deficiency, mineralocorticoid deficiency. Then the other conditions which can produce are patients who have renal pathologies like nephritis or tubular acidosis, or even patients who are on osmotic diuretics like mannitol, the hyponatremia can occur. And their identification is the urine sodium concentration can be assessed, which will be less than 20 millimoles. And the patients who have vomiting, diarrhea, or the patients who have like burns or pancreatitis, or patients who have trauma also can develop the hyponatremia. But in that condition, the urine sodium concentration will be much lesser than 10 ml. In the patients who have renal pathologies, the urine sodium concentration will be higher than 20 millimoles, whereas in the patients who have extrarenal causes, it will be less than 10 millimoles as such. And in such conditions, the treatment will be isotonic saline. Usually isotonic saline, or many times we may give hypertonic saline also, till the sodium level is normal. Now we give hypertonic saline like sodium 0.3 percentage is often given, saline 0.3 percentage is often given, with an idea of hypertonic saline where a lesser volume would be enough to produce the balance as such. Then the patients who have euvolemic hyponatremia, it can occur due to again glucocorticoid deficiency, hypothyroidism, psychiatric disorder, severe pain as such, and many times the patients who have ADH secretion abnormalities. And that in such patients, often there is no need of any intervention. Simply reducing the water intake could be enough in such patients. And the other conditions where there would be hypovolemia could occur due to nephrotic syndrome, cardiac failure, or cirrhosis, and or renal failure conditions. In these conditions, urinary sodium concentration will be much less than 10 millimoles, particularly in nephrotic syndrome conditions, whereas in cardiac renal failure conditions it will be more. And in these conditions, the treatment has to be providing sodium and water restriction, both has to be restricted. But the primary treatment will be to the renal pathology as such. That's about the types of hyponatremia. The hyponatremia symptoms could be nausea, vomiting, headache, confusion, lethargy, fatigue, appetite loss, restlessness and irritability, and muscle weakness and spasms. In severe conditions, there even could be seizures, or even there could be decreased consciousness or coma. And usually it is categorized as mild, moderate, and profound or severe. Mild is when the level is in between 130 to 134 millimoles, and moderate is when it is between 125 to 29, and the profound is when less than 125. Profound is acute emergency where you need to administer intravenous hypertonic saline as early as possible. Moderate, of course, it can be managed moderate as such. Mild conditions can be managed mainly with the oral supplements wherever the patient is able to take orally. In severe conditions, to confirm the diagnosis of hyponatremia, you may examine the urinary osmolarity or serum osmolarity or urinary sodium concentration, or maybe CT scan where there could be demyelination syndromes. Brain may show the demyelination syndromes also in case of particularly long existing hyponatremia conditions. So that's another of the issue. Particularly in patients who present with the cerebral symptoms, like which often mimics the stroke symptoms, this is a necessary issue to make the diagnosis. CT scan may be helpful. And I consider these as the Vataja Krishna Vyadhi. The typical hyponatremia symptoms are presented in Vataja Krishna conditions, and that's what is mentioned in Sushruta as a शुष्कास्थित मार्गसंभवायां तोदस्तुता शङ्खशिरस्सु चापि स्रोतो निरोधो विरसञ्च वक्त्रं शीताभिः अर्दिश्च विवृद्धिमेति. It aggravates by administering more water. That's the issue. And in a hyponatremia in general, if you administer simply plain water, the condition would aggravate. And the symptoms would be the management is usually in very severe symptoms. 3% sodium chloride is infused intravenously over 10 minutes. Maybe multiple 3 units, maximum of 3 units can be given. Mild to moderate symptoms in patients at low risk of herniation, brain herniation, 3% sodium chloride infused at and 0.5 to 2 milliliter per kilogram per hour. That's about one of the conditions. Then in case of inappropriate ADH secretions, patients who have inappropriate ADH secretions, hypertonic saline or sodium can be given, particularly to enhance the sodium value by 5 millimoles per liter and never more than 12 millimoles. So in a not very high concentration, in between 5 moles to 12 moles. That's a 3% is the usual prescription. Restriction of water intake and enhancing sodium intake orally, and patients with reduced circulating volume, 0.9% saline, that's normal saline, or Ringer's lactate could be given. Lithium supplements, patients who have lithium on very chronic conditions could be treated, particularly with the psychiatric symptoms. Lithium supplements are often given. Then oral administration of drugs also are now used where you will have the ADH hormone preparations which are available in the market as such. These also are given. That's about the hypernatremia. Then the hypokalemia, the potassium level being altered, reduced, is one more. The normal potassium level is around less than 3.5 milliequivalents per liter. And if that, and when it's less than 3.5 milliequivalents per liter, then it's considered as a hypokalemia. If the patient is diabetic and he gets insulin, then the potassium level may get altered quite remarkably, and in such conditions you have to be more careful. Patients who have ketoacidosis, the potassium is lost in the urine and they have a high tendency to develop hypokalemia. And beta-adrenergic drugs or epinephrine conditions, patients who are administering on drugs of epinephrine or beta-adrenergic drugs, they also have a high risk of hyponatremia. The causes are mainly decreased intake of potassium or increased potassium loss, as in patients who are on chronic diuretics, patients who have an acid-base imbalance, patients who have a trauma, or patients who have altered aldosterone secretion, or patients who have a sudden changes in the IV fluids, like patients who are on rapid IV fluid administration, where intracellular fluid and extracellular fluid is redistributed suddenly. That's as in patients who have undergone a shock and you treat that shock patient with IV fluids. There will be a shift of fluid from intracellular to the extracellular compartment, and this shift can temporarily produce a hypokalemia. But that doesn't require a prolonged treatment if you have provided sufficient quantities of balanced fluid. Then there may not be a need for an acute intervention. If the fluid is not balanced, then that could be a reason for worry. The clinical manifestations of hypokalemia are patients may have a neuromuscular disorders like weakness, flaccid paralysis, or even severe, very critical condition could be respiratory arrest, or dysarrhythmias, arrhythmias, and in the ECG, it's a typical that there will be a U wave seen. The typically ECG will show a U wave. After the T wave, there will be a elevation, and that's very characteristic. Other clinical symptoms could be postural hypotension, where the patient may feel giddiness, and the most serious condition would be cardiac arrest or can. Treatment: the potassium intake has to be increased as far as possible slowly and preferably by oral route. The administration of potassium by intravenous route has a high risk in the sense a sudden change in the potassium level can result in cardiac arrest. Particularly significantly important if the patient is on digoxin therapy. So it's always better that the potassium supplement is given by oral route than parenteral route. Parenteral potassium administration needs an acute monitoring, continuous monitoring, and only in ICU conditions a parenteral potassium is given. And the ECG changes which are produced due to potassium are very classical. When the potassium level is less than 2.7, very low conditions, then there could be a typical presentation of ECG changes, very severe changes, where the total amplitude of QRS would be increased. There will be increased QRS complex. PR interval tends to be prolonged as such. This interval will be more than zero 0.8 as such. Then T wave would be flattening as it tends to get inverted. ST wave gets depressed, which often can produce an abnormality which mimics that of ischemic pathology. And as I told you earlier, it's the prominent U waves and particularly seen in the V1 to V3, V5 leads as such. And QT interval also is longer than other conditions, and this would be the changes seen in hyponatremia, hypokalemia as such. And the hypokalemia types are again, they are categorized into spurious hypokalemia conditions and true. And true hypokalemia is a condition which requires an immediate treatment. Spurious hypokalemia can occur as in case of that fluid shift, where you have given IV fluids in a patient of shock. That's also categorized as a spurious hypokalemia, which doesn't require an immediate emergency treatment. All that you have to do, wait for a few hours. Whereas if the hypokalemia is known to be produced due to other causes, where there is a this abnormality related to the metabolism of other ways, then that condition has to be treated. Then the other way to manage the conditions, the diagnosis would be urinary potassium level is one of the criteria often theoretically suggested. Practically we don't do that, but urinary potassium level would be a criteria to decide about the management possibilities. If the potassium level in the urine is less than 20 ml, 20 millimoles, then it could be extrarenal causes like diarrhea or vomiting. Whereas if it is more than 20 ml, 20 millimoles, then it could be due to either the renal pathologies like tubular necrosis, or patients who are on aminoglycoside drugs like gentamicin also can produce that, or the patients who have a renal obstruction. Or it also may be presented with the metabolic acidosis like renal tubular acidosis or diabetic acidosis. If the patient of a hypokalemia also has a high bicarbonate level, then it could be due to hypertension, and particularly due to hormonal changes like hyperaldosteronism or Cushing syndrome or so on. Whereas low blood pressure, if the patient has a low blood pressure, it could be due to diuretic, vomiting and so on. So the causes of hypokalemia can be assessed by a bit thorough assessment. But irrespective of the causes, the basic treatment is it has to be identified properly and treated properly. And the clinical symptoms of hypokalemia, they are comparable to the Pittaja Trishna Vyadhi, where Murcha, Pralapa, Aruchi Bhaktashosaha, Pitekshana Tum Pratrashitaha, Shitapikam Mukhatiktaja, Pittakmikayam Parisopanancha. So the clinical symptoms resemble that of the Pittaja Trishna Vyadhi, and one of the drugs which can produce some significant benefits in chronic hypokalemia is a sarivadhyasava. Along with the other drugs, depending upon the patient's condition, I would be prescribing sarivadhyasava in patients who have hypokalemia. The management of hypokalemia in the otherwise conditions would be, it has to be supplementing of potassium or potassium sparing diuretics like aldactone has to be given. Particularly in the patients who have a renal pathology, aldactone is one of the drug of choice which has to be given, and supplementing with the potassium chloride, oral is always preferable. If there is a known cause of loss of potassium, that has to be managed. Another of the drug which can give, particularly in renal pathologies, which can produce hypernatremia, enalapril, that's AC inhibitors, is one of the drugs in certain cases, particularly in patients who have renal pathologies. It's preferred. In diabetic ketoacidosis, it's not the potassium chloride but potassium phosphate has to be prescribed, because potassium chloride can enhance the acidosis, and hence potassium phosphate is preferred in diabetic ketoacidosis to supplement potassium. That's about the management of hypokalemia. Clinically, that's more important than hyperkalemia. Hyperkalemia is less common than the hypokalemia. Uh, Now, in the potassium level is more than 5.5 milliequivalents per liter, that's considered as a hyperkalemia. And in such conditions, the most important condition which you have to rule out is renal diseases. Patients who have renal diseases, or there is a severe cellular trauma, or insulin deficiency, patients who have hormonal pathologies like Addison diseases, or patients who are on aldactone therapy for a long time, potassium sparing diuretics like aldactone. And if the patients have alkaline situation or acidosis conditions, decreased blood pH, and exercise also can make the potassium move out of the cells, and temporarily there could be hyperkalemia. A spurious hyperkalemia can occur when the patients have a severe thrombocytosis or leukocytosis due to any other conditions. Patients who have any infective pathology, or maybe in cases of leukemias where the total cell count may be higher, there could be hyperkalemia. That's considered as spurious hyperkalemia because the total blood cell count is increased. Or it also can occur in the patients who have hemolysis. A temporarily a hypokalemia may be seen in a blood sample taken from a hand where a tourniquet is placed and the patient is made to clench the fist for a long duration, repeatedly, and because there is a stasis, the venous blood may have an increased potassium level, and that can again result in an error of assessment that has to be calculated. And the clinical manifestation would be the hyperactive muscles. The muscles would be more active. Patient would have even jerks, or at times it could be tremors also could be seen. Altered sensation, paresthesia is also can be seen. Or in the later stages, there could be weakness of the muscles or flaccid paralysis. So initially, in the early stages, there will be hyperactive muscles. The muscle tone would be increased, and there could be spasm of the muscles. But later, it can result in the paralysis. Changes in the ECG also are characteristic feature where there will be a dysarrhythmias. Arrhythmias can occur, or bradycardia, heart rate can be reduced, even heart block can occur, or even cardiac arrest also can occur in hyperkalemia conditions. The typical ECG presentation of hyperkalemia, particularly if the level is more than 6.5 milliequivalents, which can result in the paralysis of atrium, particularly in the initial stages, the P wave becomes widened and flattened. Now, as you see in this, the P waves become widened and flattened, and PR segment becomes increased, and P waves gradually disappear, rather they become flat, and you will not be able to make out the P waves at all. And if the sodium, this potassium level is more than 7 milliequivalents per condition as such, then the QRS interval becomes very prolonged, and that would become very significantly abnormal. There will be shape of the QRS complex will be significantly altered, and even there could be AV block also can occur. Arrhythmias of different sorts can occur. Now, this is the typical bizarre QRS complex where the total QRS complex has become widened. There would be even sinus bradycardia, and there could be what we call as a preterminal rhythm. The rhythm which is completely altered, arrhythmias could occur as such. Treatment for hyperkalemia, if there is sufficient time, then decrease intake and increase the renal excretion by giving diuretics. If the patient is a diabetic, insulin plus glucose is given. Bicarbonate is the other drug which can comparatively produce a balance in the potassium level. And calcium also counters the effect on the heart. In the cardiac complications, calcium is given as a symptomatic treatment to prevent the cardiac complications. That's about the management of hyperkalemia. The next is about the calcium abnormality. The normal calcium regulation in the body is dependent on the parathyroid hormone and vitamin D, as well as the stored calcium in the bone in the form of inorganic calcium is another of the issue. See, there will be a continuous mobilization of the non-ionic calcium stored in the bone, which is controlled by the parathyroid hormone and vitamin D. The vitamin D will also help in retaining the calcium level in the body by acting on the kidney so that the calcium excretion is reduced and the calcium absorption from the gastrointestinal tract is enhanced. So this will result in increasing the calcium. Vitamin D helps in increasing the serum calcium level. Parathyroid hormone also mobilizes the bone and the bone calcium would be mobilized as such. So this way the main two important aspects which regulate the calcium level are parathyroid hormone and vitamin D. The calcium level could be reduced in the body, where particularly we assess the ionized calcium level in the plasma. Non-ionized calcium level in the bone is not easily assessed as such, which again can be having a low phosphate situation, which could occur due to vitamin deficiency, pancreatitis, or patients who are on antiepileptic drugs, or blood transfusions because of the citrate given, or patients who are on biphosphonate drugs, like biphosphonates are again used as antipsychotic drugs. And in these conditions, it could be like there could be a low phosphate and hypocalcium. Calcium level could be low. A low calcium also can occur due to hypoparathyroidism or patients who have lower magnesium levels also. Or patients who may have a normal phosphate levels. It can occur due to high parathyroid hormone acid or acute renal failure, or there could be in the patients who have skeletal muscle lysis, rhabdomyolysis, particularly patients who are on statins in high doses, there could be rhabdomyolysis as a complication, and this also can result in the same. Or tumor lysis, patients who are on chemotherapy for tumor also may have a hypocalcemia at times, or patients who have a hypoparathyroidism. If the patients have a removed parathyroid gland, as in case of thyroidectomy, they may have a severe hypocalcemia. Hypercalcemia can occur if the patient's urinary calcium excretion is more, and particularly if the urinary excretion is more, it can be due to the either abnormality of the bone metabolism, due to parathyroid hormone abnormality, and if the parathyroid hormone abnormality, it could occur due to primary hyperparathyroidism, or the hyperparathyroidism produced as a secondary effect of drugs. If the parathyroid hormone is lower, then there could be osteolytic lesions like tumors of the bone which can produce hypercalcemia, or endocrine pathologies like hyperthyroidism also can present with hypercalcemia, or patients who have immobilization, continuous immobilization, and hence the bone is not moving about, or there is no mobility of the bones in patients who are paralyzed, bedridden for a long time. It can result in hypercalcemia. Hypercalcemia also can occur due to increased gastrointestinal absorption, and one of the very common condition which was well known or which is established is milk alkali syndrome. Milk alkali syndrome is in the patients who had gastric irritations, gastritis like symptoms. The earlier prescriptions were alkalizers, alkaline drugs were being used to reduce the acid content, acid pH, and in such patients if the milk is consumed, that will enhance the calcium absorption, and that would be a cause for this hypercalcemia. But these days the drug of choice in case of gastrointestinal tract pathologies would be the calcium, the histamine 2 H2 receptor blockers, or proton pump inhibitors, so which may not have the same complications as such. So that's one. And the other is if the patient is given excess of vitamin D overdoses. That's another very common situation. Vitamin D increase in the body, hypervitaminosis of vitamin D, which can occur due to excess of administration. This also can occur quite frequently, or at times it could be also produced due to excess in sarcoidosis, or patients who have granulomatous disorder like leprosy, or fungal infection conditions. The total calcium level may be raised in the body. Then if the patients have the urinary sodium level, urinary calcium level is lower, it could be due to abnormally renal absorption, which could be again due to chronic diuretic uses, particularly diuretics like furosemide. Patients who are on lithium drug, lithium is an antipsychotic drug even as such. Or patients may have some genetic pathologies, it can occur. The clinical symptoms of hypercalcemia and hypocalcemia are almost many times would be confusing. The symptoms could be CNS, hypocalcemia produces irritability, anxiety, abnormal sensations, seizures, spasm of the larynx and bronchi. On CVS, it may result in heart failure and muscle cramps could occur. Whereas hypercalcemia can present with the decreased ability to concentrate and increased sleep requirement, depression, confusion, and coma also can result in death. CVS symptoms of hypercalcemia could be arrhythmias, particularly bradycardia, and the muscle weakness could be the symptoms of hypercalcemia. The ECG evidence of hypo and hypercalcemia are very characteristic. The hypercalcemia would have a prolonged QT interval of more than 0.48, whereas hypercalcemia would have a shorter QT interval of like 0.26, whereas the normal QT interval is 0.36. So QT interval is Q to T. So the typical evidence would be in a hypercalcemia there would be a tachycardia and the total QT interval will be shorter. Short waves are produced. In hypocalcemia, long waves, wider waves are produced. That's how the evidences are made out as such. Treatment for hypocalcemia would be the oral calcium dose should be given, maximum dose should not be more than 1005 milligram per day maximum, and not less than, not more than that, any cost. But ideally, it should be at a lower dose, and doses should be. It's only for a severe hypocalcemia that high dose is preferred, and it should be decreased if the calcium level raises above 10 milligram. So it should not be continued till the calcium level is more than 10 milligram per DL. Then the other one is calcitriol hormones also can be given at a dose of 0.25 to 0.5 micrograms orally daily is also given. Another of the drug is cinacalcet, which is now not so popular, is also considered as a calcium mimetic agent, and it helps in absorption of calcium from the body. 30 to 90 milligram is often given in such patients. Hypercalcemia is treated mainly by hydration and dietary calcium restriction, where the calcium should not be more than 400 milligram per day. The total quantity should be maintained at a level of 400 milligram. And we get the patients of hypercalcemia because of excess of calcium administration. These days, consumption of calcium has become a fashion, and particularly middle-aged women, they would be taking calcium regularly, and it's unnecessary, and that can result in a hypercalcemia, and in such conditions that calcium content has to be reduced. Saline administration could be used in severe acute hypercalcemia conditions, which are comparatively less common from the clinical point of view. Diuretics like furosemide is also another of the drug which is often preferred. Glucocorticoids help in reducing the intestinal absorption and tubular reabsorption of calcium, which also is another condition option, particularly in the patients who have renal diseases, nephrotic syndrome-like conditions. Glucocorticoids could be the used drugs. Calcitonin could also be used in hypercalcemia, and the rarely mitramycin, an antibiotic, also is used in case of hypercalcemia, rarely. Phosphorus soda, the phosphorus is given particularly in sclerosis-like conditions, systemic sclerosis-like conditions. Phosphorus soda, sodium phosphate is given at 5 milliliter as such. With this, we will conclude these fluid imbalance conditions. The next part of the udakavaha sources would be about the prameha, which we discuss in the next session. So, if there are any questions, we'll try to answer. Then we'll wind up. No questions, so we will wind up today. We'll continue in the next session. Right.